Good afternoon, everyone. It's top of that hour, and welcome to the last presentation for this semester, or this academic year for that matter. And we'll be back after the summer. So this is really, really special. So thank you for joining us today from near or far, and we are thrilled to have you here for this exciting presentation. My name is Dare, as usual, your host. And as a reminder, this webinar is being recorded and it will be on our YouTube channel upon the presenter's permission, securing the presenter's permission. If you have any questions throughout the presentation, please feel free to use our chat feature, and hopefully we'll have some time for some Q&A at the end. And please try to engage. And we encourage you to actively participate because this is such an important topic that needs to be addressed, especially under current political climate. Now let's talk about what we can expect today. We're honored to have Dr. Daryl Traylor with us again. And I don't know if Dr. Anderson will jump in or not, but that completely depends on how they work it out between the two of them, our resident scholars at ATSU. So Dr. Traylor is currently with CGHS and Chamberlain, as you know. And we are so excited to have him again with us. Without further delay, let's jump in. And I hand it over to you, Dr. Traylor.
Hey, thanks, Deb, and thanks for this opportunity to present this work. Never thought that Ebony and I would end up doing anything in climate change, but one of my mentees, I think this was always part of her evil, nefarious plot to bring us over into climate change and lactation and breastfeeding medicine, and so that's where we sort of are now. But anyway, so this presentation today is going to detail a climate change model that she and I have been developing. So it's really sort of the outgrowth of two manuscripts that we recently had submitted. One where we actually outline and highlight the model itself, and the other was sort of a spinoff where we were examining or are examining the intersections of climate change, water use, and AI data centers, and how that potentially is impacting pregnancy and lactating individuals. It's really important work. You don't, since I've been a medical student, I haven't had any sort of coursework or anything pertaining to climate change, nothing in my MPH, but it doesn't take too much imagination to imagine that heat stress and climate change and water usage and all these things do ultimately have an impact on pregnant and lactating individuals, and of course, all of us. All right, so let me see if my technology is working today. All right, so hopefully you can all see that. So I want to really begin this presentation by really framing the presentation again from the two related articles that Ebony and I developed. So these two papers are really the whole genesis of this presentation. So the first article, Climate Responsive Maternal Care, Heat Equity and Maternal Care Systems, really focused on heat as a maternal health equity issue. Our second paper, AI Data Centers, Water Use, and Maternal Health, really expands that concern to water, digital infrastructure, and environmental justice as a maternal health equity issue as well. So together, both of those papers really sort of form an arc for heat exposure, water security, or in this case, potentially insecurity, from clinical vulnerabilities to upstream infrastructure, and from individual risk all the way to institutional responsibility to think about mitigating these things for pregnant and lactating individuals. We really argue that maternal health research can't only remain focused on what's happening in the clinic. We have to start to examine the housing, cooling access, cooling centers, green spaces, water security, how our infrastructure pertaining to AI data centers and things like that ultimately are playing a role in maternal health equity. And overall, we need to consider how, like, what the responsibility of overall health systems are to helping to mitigate environmental risk before we start to see really bad adverse maternal health outcomes. All right. So a really central idea for us is that climate stress is really a layered sort of process. It's not just a singular sort of process. So, for pregnant and lactating individuals, climate stress really operates across several levels all at once. So, first, you're thinking about your environmental exposures. You think about heat, humidity, limited access to cooling centers. Think about the water insecurity. Think about the built environment, the way our homes, our neighborhoods, workplaces, care settings are actually built. However, the exposure doesn't just act on a neutral body, right? So pregnancy and lactation itself involve physiologic adaptations related to thermoregulation, fluid balance, cardiovascular demand, metabolism, excuse me, and then lactation related hydration needs, both for the mother and their infants. So that means that those same environmental exposures can carry different consequences during pregnancy and then during that postpartum period. Climate stress is also psychosocial. So people might be navigating worry about their water access, transportation, childcare, employment demands, their housing quality, utility costs, groceries, the ability to even take care of themselves and keep themselves cool during a hot day. And then finally, climate stress is really also a systems level issue that we need to think about. Health systems may or may not even have protocols for how they deal with heat events, screening tools. So, for example, there's a family medicine practitioner that I've been following for the last year. She'd never really thought about screening her patients for climate related risk. Something that she and I were talking about recently. And she said, "Oh, this is something I've never really talked about." You're thinking about patient education, workflows within the clinic related to heat stress. Does a health system have any sort of cooling plans or cooling infrastructure in place or outreach mechanisms when we see heat and water emergencies? Think about Phoenix. Now we're entering the time of the year where we're going to start to see heat and water emergencies, and how many of our hospitals, in the city actually have cooling centers, for people to gain access to. So the health equity point of this is that maternal risk is really patterned by exposure and the adaptive capacity of the individual and the systems that surround themselves. Unequal exposure plus unequal ability to respond is ultimately what's producing this unequal maternal risk. So our first paper responds to a big gap that we've seen across the literature, growing evidence that's leaking heat exposure to adverse maternal and infant outcomes. And I want to note that most of the evidence is in animal models, so not a lot out there that's looking at humans. But anyway, there's a lot of strong work that also is examining this from an environmental justice perspective, health system sustainability perspective, and reproductive justice, but a lot of the literature isn't linked. They operate in parallel, but not really linked. Climate science gives us really good exposure data. Obstetric epidemiology gives us some associations with some outcomes. Bioethics and reproductive justice really help us to understand the unequal distribution of the risk. The health system sustainability literature is really telling us that healthcare organizations have climate responsibilities, but nothing's linked. We were not able to identify any model that links all of these things together. So our framework was developed to address some of these gaps. So fragmentation across the disciplines, insufficient attention to equity, insufficient attention to pregnancy and lactation physiology, and the absence of practical domains and indicators that health systems can use as they're considering these issues. So our goal wasn't just to describe the vulnerability. I think that's fairly well covered in the literature. It was really to create a model that can guide clinical practice, public health practice, and health systems planning, and ultimately future empirical research in this area. So this slide presents the model and what the equation really means. So we developed the CRMC framework through analytic literature synthesis. We're not doing just a narrow sort of systematic review on one exposure or one outcome. Instead, we really integrated multiple pieces of literature that each explain a piece of the problem. So we started with a scoping review of empirical and conceptual literature related to heat exposure, pregnancy, lactation, climate resilient health systems, environmental justice, a lot of other stuff. I won't name it all, but this really helped us to establish an empirical baseline that there actually is a problem. Then we integrated ethical and theoretical perspectives, particularly from reproductive justice, distributive justice, and feminist bioethics, as well as corporate social responsibility. I think that was a big piece for us. This matters because climate-related maternal risk is not just biologic, it's also institutional and moral. So let me say that once again. This issue is not just biologic or physiologic. It really is a moral issue that we need to address. So then we use thematic clustering. So initially, five major clusters sort of emerged. So environmental exposures, maternal biophysiology, the social determinants, health system responses and outcomes. And from there, we use structural modeling to examine how the clusters really relate to one another. We didn't just want a list of different factors. You can probably pick up any textbook or any journal article and just see a whole list of what's related, but we wanted to know how these things really relate to each other to influence risk. So then we compared the model with, for example, to other frameworks like the World Health Organization's Climate Resilient Health Systems Framework, ecological systems theory, and that helped us to sort of assess whether our model was really aligned with established systems thinking while still offering something that we hope is going to be novel and specific to maternal health. So the key construct decision was the addition of that sixth domain, mitigation and co-benefits. We decided to add that because health systems are not just responding or should respond to climate change. They should also, they're also institutional actors that can either work to mitigate or perpetuate some of the climate risk that maternal people will face. And so that equation that you see, uh, are you to see? So the equation that you see really sort of summarizes the whole architecture of our model. Um, in plain language, what we're saying is that outcomes arise from the interaction of environmental exposure, maternal vulnerability, or biophysiology, and social and structural modifiers. Those factors operate within the moderating influences of health systems responsiveness, or, like I say, thinking about the corporate social responsibility as well. Over time, mitigation and co-benefit strategies can reduce exposure and strengthen systems responsibility. So E is for environmental exposures. So you think about heat intensity, humidity, air quality, the built environment, urban heat island effect, those sort of things. V is maternal biophysiology. So the thermal regulation, hydration, cardiovascular health, those things. S is for social and structural modifiers. So think about housing, occupation, income, transportation, basically social determinants of health. O represents our outcomes. So dehydration, hypertensive disorders, preterm birth, lactation difficulties, those sort of things. And M is mitigation and co-benefit strategies. So think about emissions reduction, sustainable cooling, resilient infrastructure, institutional practices that can help to mitigate the cooling and so forth. That multiplication sign is very intentional because that suggests that these domains don't just add together, they actually interact. So, in other words, it's a sort of a wow, I'm trying to say, I can't see if I can say the word. Just a multiplied effect is what I'm trying to say. A given heat exposure has different implications depending on the individual, their physiology, housing, employment, water access, and things like that. But all of these things will multiply together as opposed to just simply an additive effect. In other words, you can get a much greater effect depending on that person and those sort of things there. And so this slide is actually our framework. The figure organizes climate-related maternal health risk into the six domains that I mentioned before, and each box represents a different point where risk is produced, modified, measured, or possibly prevented. The first box, environmental exposure, represented by the E. That refers to the external climate-related stressors that pregnant and lactating individuals, postpartum individuals, may encounter. The second box is maternal and infant physiology, represented by V. That domain, we think, explains why pregnancy, lactation, and infant care are really sensitive periods that deserve that intervention. Excuse me. The third box is the social and structural modifiers, represented by S. That domain explains why climate risk is not evenly distributed. So again, thinking about those social determinants of health. The center box is the health systems responsiveness, represented by H. That includes governance, law, policy, healthcare delivery, workforce training, all of those things. And then the outcomes box represents the measurable maternal lactation and infant consequences that can result from all of these domains interacting, good or bad. The final box is the heat mitigation and co-benefits, represented by M. That represents the long-term responsibility of healthcare organizations, or corporate social responsibility in institutions, think about things like the sustainable infrastructure, emissions reduction, community resilience, and those sort of things there. The arrows show how the different domains relate to one another. So the solid arrows represent the primary actionable pathways in the framework. They show how environmental exposures, maternal and infant physiology, social structural modifiers are all interacting with health systems responsiveness, and that health system responsiveness then is helping to shape outcomes. The dash arrows represent indirect or background sort of pathways. They remind us that environmental exposure and structural conditions can really influence outcomes beyond the immediate clinical effects that we see in the clinic. So, for example, heat exposure can affect maternal and infant outcomes directly if a person lacks cooling access, hydration access, safe housing, transportation, what have you. In a similar way, the social and structural, I'm sorry, the social and structural conditions can shape whether the mitigation strategies are actually equitably distributed and whether communities are actually benefiting from investments in resilience and mitigation strategies. Um, we also envision this as being able to operate at different levels. So you think about at the macro level. So, Ebony, this is a call out to you and your social work background when we worked on this. The macro level is really informing policy, governance, climate resilience planning, corporate social responsibility, those sort of things. The meso level, the framework can guide facility and organizational operations. So thinking about what a clinic or a hospital can actually do to play a role in mitigating this. And at the micro level, this is actually the clinical care, the individual clinical care, or the public health level. So what is it that health navigator or that individual clinician can do in terms of maybe screening for exposure, cooling access, hydration status, and things like that. Um, so that's a nice description of the model. So moving on. Um, so where we are now. So the next phase of our work is to hopefully develop this so that we can field test it. Right now, we think that this is conceptually coherent, but we've got to field test it to see if it actually does what we think it's going to do. So we've got to refine the constructs. So we're going to get feedback from maternal health clinicians, climate change scholars and experts, implementation scientists. We've actually got a connection with Meharry Medical College and the NMA Climate Consortium, and they're connecting us to some people who are doing work in this area. This is going to be a really important stage for us because they'll let us know if there's anything missing, maybe we've got too much, whatever, but they can basically help us to figure out if this is theoretically sound. The next stage is also, or after that, will be tool development. So we'll need to actually develop some actual tools, questionnaires, for example, a heat risk screening, workflows, some patient-facing counseling scripts, those sort of things that can be used to help with validating the model. Then we will have to do a pilot implementation. So we have a mentor out at UNLV who's been working with me to get some training in implementation science so that we can make sure that we're using the latest and greatest in science to be able to implement this. Then obviously we'll have to do some evaluation work to assess the feasibility, accessibility, documentation burden, all these things, just basically to see if this is actually going to be usable. Like I said, we have this relationship with the National Medical Association's Climate Change Consortium, and through that relationship, we may actually be able to access a pot of money. They recently uh, put out I think it's 300,000 or $350,000 for scholars doing work in climate change. So if we can get access to that money, then we can actually implement this and do some real science. So ultimately, the real goal of all of this is just to determine can the CRMC model really help clinicians and health systems see climate related maternal risk and then act more consistently across all of these domains to mitigate climate change in these individuals. So our second paper then really extended the work that we did. So we see all this stuff in the news now about the development of AI data centers. I was just reading a few days ago in my home state of Texas. The state has given permits to build. I think I don't remember if it was 60,000 acres or 6,000 acres, but it's just going to be this massive data center project larger than anything that we've seen in the United States so far. And they were saying that it's poised to potentially use something like 5 million gallons of water per day from the aquifer. And, consider that the city of Corpus Christi, Texas, could literally run out of water this summer. That's huge. And we're not saying that AI data centers are good or bad. We really don't know one way or another. But in this paper, what we were saying is that we need to consider the impact that they're having on the population. Frequently the AI data centers are discussed in terms of innovation, the energy demands, carbon emissions, but again, they also require water. And so there's a growing body of research that's looking at the water usage, but nobody has really started to look at how the AI data centers and their water usage is impacting maternal care. So again, our argument isn't that data centers have already been proven to cause adverse maternal or infant health outcomes, because we don't know that. At the present, there's no direct epidemiologic studies that we could locate that even link AI data center water usage to maternal health outcomes one way or another. Instead, what we're saying is we're just basically making a conceptual and precautionary public health argument. If AI data centers increase water demand in a water stressed region, and if household water insecurity is already linked to dehydration, hygiene constraints, stress, caregiving burdens, then maternal health researchers really do need to pay attention to this. And again, this really matters because pregnancy and lactation are periods of heightened water need, heat sensitivity. So water isn't just simply a household utility that we all need. It really does support hydration, hygiene, postpartum recovery, infant feeding, and heat mitigation in this population. So basically, our central claim is that AI infrastructure really needs to become a very visible part in environmental health and maternal child health surveillance. We really do need to understand how water usage by data centers potentially impacts stress and heat burden and overall maternal health outcomes. So this graphic really kind of lays out the pathway that we're proposing. This is again from our second paper. On the left side, the starting point is AI data center expansion. So these facilities really require a lot of water, direct on-site water for cooling, and then indirect off-site water for the electricity generation. The exact water burden really depends on the facility design, the cooling technology that's built into the facility, climate energy resources, and whether potable or reclaimed water is used. As I just mentioned, the new center that's going in out in West Texas is going to be drawing water directly from the aquifer. Then moving towards the center of the framework, the demand can contribute potentially to local water systems pressure. This doesn't mean that every data center contains or creates household water insecurity. The context matters. For example, the size, whether or not it's already in a water insecure environment. But in those water stress settings, if you have weak governance or if you have a large mass of data centers being built, That increases competition for that water. Then it ends up ultimately reducing flexibility during drought conditions. Again, think about Corpus Christi, Texas, the data centers that they have in and around the city, and the water that they're drawing out of the aquifer. Literally, I mean, they're literally saying that Corpus Christi could run out of water this summer for people to literally drink and take baths and cook and things like that. Um, then the central moderator in our picture, again, is household water insecurity. So that's the point at which infrastructure issues become a household health issue. From there, the model branches into a few different pathways, dehydration and thermal strain. So pregnant and lactating individuals really do need that reliable hydration, and heat actually ends up intensifying their fluid needs. The second pathway is hygiene and infection. So water scarcity affects hand washing, bathing, basically personal care, and that has a link to hygiene, or I'm sorry, infectious diseases and things like that. The third pathway is the psychosocial stress and care burden. Water insecurity can create worry, planning issues, time burdens, difficult trade-offs that individuals have to make when they're considering, okay, well, do I spend money potentially going out to, buy bottles of water, or do I spend money on my electric bill, what have you, just creates potential issues. And for someone who's postpartum, those stressors can really affect their recovery, their ability to actually be a caregiver, and ultimately their emotional well-being. That fourth pathway is the structural inequities. Data center sitting, it doesn't occur on a blank map, right? There's a lot of research now showing that these data centers are being built in underserved, underrepresented communities, communities that are already facing a lot of environmental disadvantages. So they have less power to even contest, the siting of these facilities. Just right here in Phoenix, if I'm not mistaken, I think it was Kirsten Sinema was trying to strong arm Gilbert into having a water center, or I'm sorry, AI center built in Gilbert, and the community raised bloody hell, and they backed off on that like that. But as I understand it, there's plans now to site that center somewhere over here in the South Phoenix area, a community that's undergone historical redlining, a community that is heavily Spanish speaking. A lot of African American individuals live here, a community with less political power than Gilbert, Arizona, right? And we know that South Phoenix is definitely a water insecure region of the Phoenix area. And so the top of the graphic just shows amplifiers. So you're thinking about the drought prone settings, water stressed watersheds, rapid development, weak governance, and transparency, sort of what we have in Texas. And then the bottom will show points of prevention. So disclosing how much water is actually being used. In Texas, there's a loophole where these facilities don't actually have to disclose accurately how much water they're actually using, right? We need to have household protections during droughts or extreme heat events, maternal informed permitting of these data centers, and then again, the clinical screening for water insecurity and heat vulnerability. And so, again, we're not presenting this as a causal model. This is just sort of a conceptual pathway that we developed as we're sort of thinking about this, and hopefully, this could be a tool that can be used to guide surveillance, research, and clinical awareness, and ultimately some policy development. So, our next step. Again, we're going to be exploring this with physicians from the National Medical Association's Climate Change Consortium and Meharry Medical College. Dr. Brianna Clark is a good friend and a mentor of mine. She's a family medicine physician out of Missouri, and she's also in the PhD program in global health out there at Meharry. Like I said, we've been working with her since 2021, and slowly but surely she's been pulling us in. She baited me. She was like, "Hey, Daryl, you want to work on this paper?" Or, "Hey, Daryl, we're working on this chapter in this book. You want to work on it?" And next thing you know, here we are. Um, but anyway, Dr. Clark has been a longtime member of the NMA Climate Change Consortium. And so she connected us with some other individuals, and they may help us to get access to a pot of funding. And then again, working with some of their experts, we hope to be able to refine these pathways into something that's really meaningful that we can pilot test and then ultimately translate this into something that will be useful clinically and policy and public health wise. So this all just sort of brings together our two papers and our broader research program, hopefully, if we can get the money. So the first paper was really our framework that gave us the climate responsive maternal care model, identified our domains through which we think climate risk becomes a maternal health issue. The second paper identifies a really important emerging upstream infrastructure issue, AI data center water demand. We're asking how rapidly expanding digital infrastructure may shape water insecurity, heat vulnerability, stress, and maternal child health outcomes. And together, these papers really point towards our agenda. So we're thinking about ways that we can prevent um, or mitigate some of the climate risk that individuals who are pregnant or lactating and their children are facing. So ultimately, we don't want to just study associations after the harm has occurred. We really hope to develop frameworks and screening tools and surveillance technologies, partnerships that can help clinics and health systems and governments and public health workers or whatever to intervene earlier before that harm has actually occurred. And our view of health equity is what's actually holding our whole research program together. So we're asking who is exposed, who has the capacity to adapt, whose risks are rendered visible versus invisible, and whose risks are remaining institutionally impaired until they become really bad clinical outcomes. That's what we want to sort of prevent. And so our ultimate goal then is just to design systems that prevent the unequal environmental risk that's ultimately leading to the unequal maternal health outcomes. So I'll close with these takeaways. First, heat really is a maternal care slash systems issue. Our framework, we hope, will help to translate heat risk into domains, levels of action, and ultimately implementation indicators. Second, water is a maternal health condition, so AI data center growth may intensify pathways that matter for pregnancy, lactation, and postpartum recovery, infant care, and psychosocial stress. We don't know that yet, but something worth looking at. And third, equity is really the test of implementation. It's not enough to just create interventions and models and all these things there. We really need to ask whether these tools that we have really do reduce disparities or reproduce the disparities. Either can be true. So again, the next phase of our work is just to refine and field test the model and develop the workflows, and hopefully we'll have something that's useful. So that's it. So open for questions.
Well, thank you, Dr. Traylor. That was amazing. So much to think about. And Dr. Anderson has posted some articles for us to look through. Does anybody have any questions right now? Well, if nobody has any questions, I have one.
Mhm.
So, from the implementation perspective, to combat this, or however, take this challenge on, what do you think is more important? Community participation, organization, government kind of interference in equity measurement measures. Shouldn't say interference, but government's hand in
Right,
equity
right.
measures, or like a private public partnership in kind of creating support systems for individuals who are affected.
The way that I was trained in public health, CBPR approaches, community-based approaches, I think are vital. Um, in this instance, though, I don't know that they are going to be the most important in this. I think that if we don't approach this from a perspective of getting industry involved and getting government involved, I don't know that we'll have a lot of success if we use solely community-based, or if we, condition everything solely based on community responses. It's become apparent to me that, there's a lot of money, in these AI data centers and things like that. Um, the powers that be aren't going to let that go. Like I said, I'm thinking about my home state again, with what's going on in West Texas and Corpus Christi. The state literally wrote it into the law, these loopholes that the data centers are able to use to not accurately report the amount of water that they're using. Literally, that was written into the law. And so we've got to find policy experts and government experts and people at that level that we can work with to help. But obviously, community has to be a big part of this as well. And so this whole work has actually started to get me to rethink, um, how it is that we take action to change harmful things. I don't have answers yet, but I just don't think it's going to be a thing that we're going to be able to march or protest our way out of. I don't think it's a thing that we're going to just be able to use solely CBPR approaches to work our way out of this.
Thank you for that. That's pretty scary.
Yeah. Yeah.
Another question. Sorry, I'm going to just see if we have any questions in the chat.
Hmm.
Here's some comments. Thank you, Dr. Normore, for attending today. This is amazing. And he commented on your presentation. What are your thoughts on this thing eventually contributing to migration? Like this affect population
Oh yeah,
outcome?
absolutely. When I haven't seen anything in the literature yet that suggests that AI data centers are contributing to migration, but it doesn't take much imagination to imagine that if you're living in an area that's already water stressed and then you build this big thing that continues to contribute to water stress, that's going to drive migration patterns. I did see a papers maybe a year or 2 years ago that talked about just in general here in the United States, for example, as we start to see more water stress in the Southwest region, that's going to drive migration back to Middle America and like the area around Michigan and Wisconsin and places like that. So I think it's wholly reasonable to expect that we could see that sort of migration. I think, Deb, your question might even be more pointed if you ask, what will that potential migration pattern look like in the developing world? Here in America, we've got the mobility to go anywhere, right?
Yeah.
But what about somebody in Uganda, Ethiopia,
Yeah.
wherever? Where can they go? And there is a lot of evidence that's now showing that these data centers, again, are being built in the parts of the world where people have little voice and little ability to avoid the outcomes associated with these facilities and so forth. So that's an interesting question. Are you just trying to get me to research something else? I don't need to add anything else to my plate, but
If there's somebody who's gonna take it up, it's gonna be you. So yeah, I mean, it's just like I'm just like this list just opened up so many like scary, almost like post-apocalyptic scenarios where it's just the fertility rate drops with
yeah.
this kind of effect on maternal and fetal outcomes, child outcomes, and then people just are forced to leave, and
Mhm.
it's crazy to think
Yeah,
about that, comprehend that.
absolutely. Absolutely. Hey, Dr. Lewis.
Hey, great presentation. Thank you so much for this. I'm curious if you have any recommendations for some way for us to incorporate the topic in medical education, even just to have our students be, just to raise awareness, or
Mhm.
because I think when you said early on in your talk, basically by the time we see the outcomes, it's too late. We
Yeah.
really have to have an upstreamist approach.
Mhm.
And we're really working hard at Soma to train upstreamist physicians. But I'm wondering if you have any recommendations, even small things we could do to fit into the curriculum to, um, we don't have to debate. I don't see climate change as a debatable topic, but if
Mhm.
people do, we just are not even entering into a debate on that level, but just to say this is happening. The AI water set, data centers issue is present and current, and um, I personally hadn't thought about it as for maternal health
Mhm.
for people who are pregnant and lactating. So I so appreciate this,
Mhm.
but just um, I don't know what thoughts you have on that.
And that's interesting because, I'm a medical student too, and my other hat, and I think a lot about, how we can incorporate public health concepts in general in medical school, right?
Yeah,
Because we can't necessarily remove anything. In fact, I had this conversation with my faculty mentor at my school, and she was saying she graduated from medical school in 1978. And she was saying that the biochemistry textbook that she used, might have been 300 pages or something like that. Whereas the one we have now is, well, I could lift weights with it. That's how big it is.
wow.
Um, so I don't, and so like at my school, the way that they've incorporated public health, we have our first clinical transition unit that I'll be taking in February, and they just kind of crammed in, a couple of lectures there, but it's not in a meaningful way. And so I think that you have to look at the curriculum, obviously, to sort of see, okay, where can we meaningfully incorporate these things? So, for example, if you're in biochemistry and you're talking about a module on, nutrition, maybe incorporate instead of that whole module being based on, this is what's happening in glycolysis or whatever when you eat, have something that says, okay, well, here's a practical implication of what can happen to a pregnant or lactating individual if they don't get enough, to eat or enough water. And again, don't just focus that on the physiological piece, but really emphasize, we're not just biological sacks of chemicals, right? We're living, breathing, people, and there's implications to all of these things that either help to or hinder, people from adequate nutrition or going to
Yeah.
work or school. So I guess I'm just saying, like, we've got to figure out how we can meaningfully incorporate these things in a longitudinal manner across the curriculum, as opposed to saying, well, it's going to reside in one course at the very end. When, I mean, if I'm being honest, like I'm finishing my neuroscience block now, and in February, when I get to the clinical transition unit, I'm probably not going to I'm gonna be tired. I'm probably gonna blaze through this, go through that stuff as fast as I can because I want to
Yeah.
pass. But am I really taking the time to really sit and absorb, like, what does this mean to me as a future family medicine physician and the work that I want to do in the population that I want to work in? And of course, I recognize there's, all sorts of accreditation issues, so it's not just so easy just to put things in. But I think maybe just starting with one or two courses at a time and saying, okay, where can we thoughtfully and reasonably put some of these concepts in so that the students are getting exposure to this across the curriculum for all 4 years. Maybe you might see, physicians graduating from medical school that have a greater awareness of these type of topics.
Yeah. Excellent. Thank you.
Hmm.
And then I was just going to say an immediate action would be to talk to the students who are pursuing the dual degree.
Hmm.
Sometimes they will come to us and say, well, I really don't know what to focus on, and I honestly haven't, through this particular research out here as a suggestion, things that they could do, maybe explore at one of the clinical or non-clinical sites, wherever they choose to go. But if they, are sort of lost on what type of project to work on, this is something that both Dr. Lobet and I, can also bring up, not necessarily from a research standpoint, but like I said, kind of adding to what Dr. Apicotla just asked, what role should physicians and public health professionals play in patient education around this topic? Perhaps that dual degree student might look at ways to increase health literacy. They
Yeah.
might create literature that surrounds, this whole topic and what they can do immediately. Or maybe talk of, to other clinicians, about what they could do to boost communication that surrounds this very topic. So that's something I will definitely do as we start talking to our rising fourth years about their practicum coming up next year.
Well, and I know too, as I think about, what it's going to be like when I start clinicals, I understand that there's this whole hierarchy that we have to attend to in rotations, but maybe, medical students just having the courage to say, for example, if you're working in your family medicine rotation and you notice that your attending doesn't screen his patients for heat stress or their water need, maybe having the courage to have some conversation with that attending to say, hey, is this something you've ever thought about? Is it something that you do? I mean, as I think about my experiences with seeing our primary care doc, she doesn't ever ask anything about, well, how are you doing in terms of your heat stress? Do you have adequate cooling? Are you getting enough water? Because it's not something that you really tend to think about. And, you know, not that me and Ebony are old, but I recognize that we don't tolerate heat the way we did when we were in our 20s. And going back to your question, Deb, like, the heat here in Arizona, like we love Arizona, right? But we also recognize it's just getting hotter. And so it actually is playing a big role in our discussions about where we actually want to pitch our future tent. Where do we want to settle down permanently? Because there's
We
going to
talk
come a
about this
time
almost every day.
almost
Yeah,
every day. Yeah. So
yeah.
it
And what
really
did I
is a
tell
daily.
you in the car yesterday, Daryl? I said this heat and perimenopause doesn't mix.
Right. Yeah, I was going to say that was after you finished cursing about the heat of the leather and the metal seatbelt that touched you. But yeah, this is something that we talk about every day, and so there's a lot of points, Dr. Lewis, where I think that we can intervene and start thinking about how we can get this information out here.
Yeah, that's excellent. And maybe just like we've work like what you all are doing has advanced screening for intimate partner violence
Mhm.
and screening for wearing seatbelts. Are there guns in the house? Um,
Mhm.
Housing instability. This could be part of our routine social determinant
Mhm.
intake that for even we could start that with our SOMA students and their med skills, just
Mhm.
asking about heat and
Yeah.
so yeah, terrific.
Anything else?
I believe there's a question in the chat.
Let me see.
What role should physicians or public health professionals play in patient education around this topic?
I think it definitely starts with screening, making sure that you're asking every patient, if you're certainly in the clinical context, about their heat insecurity, water, do they have adequate air conditioning, things like that? Are they uh, having to ride the bus versus taking the car to the clinic from a public health perspective? When I was a health navigator, this was something, the organization I worked for in Phoenix, Jewish Family and Children's Services, this was actually part of our screening. Excuse me, because a lot of our clients lived in homes here in Phoenix that didn't have air conditioning. Some, didn't have fans. We actually had a pot of money where we would, buy fans for people and things like that. So again, I think, now that we live in this new era, climate change, it's here. I'm just going to go ahead and say it. I don't care what your politics are. Climate change is here, and it doesn't care about your politics. Period. Point blank. So we need to be doing the screening, and this is probably going to entail some differences in the way that we design course curricula. So for some of the public health courses that I teach, wherever I can, I implement either a full module, 1 or 2 week module, or lectures, pertaining to heat stress and the impact of heat stress. And then more importantly than that, what are practical ways that my MPH students can then graduate and go out in the field and be able to screen their clients and so forth for their heat stress domains. So overall, it's just something that we got to do, and we've got to figure out how we're going to do that. I'm not going to claim to have all the answers, especially given the politics that we're living in now. I just heard a few weeks back that the administration has closed down several of the National Oceanic Administration, their research arm. I think they had some labs in Colorado or something, and those things have closed down. So we're losing a lot of capacity to even fight. So that just means we have to fight back harder because this is something that we just absolutely have to do. For all of us that are on this Zoom today, every last one of us is going to be influenced and impacted in some kind of way by climate change. And like I said, it doesn't care about your politics. I mean, it's just a fact of the matter.
Well, any other questions for Dr. Traylor before we wrap up? Looks like I had a lot to chew on. And so that brings us to the end of today's webinar. And on behalf of ATATSRI, I want to extend a huge thank you to our incredible speaker, Dr. Traylor, and for sharing his insights and expertise. And a big thank you to all of you for joining us today and asking interesting questions. We will see you again in September. So have a great summer and keep cool in the
Drink water.
summer heat, yeah, wherever you are, and fight the good fight. Thank you for joining us
Have a
today.
great day, everybody.
Okay.